Next thing that we look at is the sequence with drowning or near drowning. So these patients will have a moment where they're fighting and panicking to struggle to get to the surface. I don't know if you were the older cousin or you were the younger cousin that went to the water park, but anytime that I went with my older cousins, they were trying to hold my shoulders down and just show who the king of the rock was. And I remember that panic. I remember that violent struggle trying to get to the surface in these situations where it's not cousins horseplaying and it's an accident. The victim will have that same panic, they'll have that same violent struggle to try to get to the surface. After that, there's going to be a period of calmness. Like it's almost like the calm before the storm. And in that, there's also going to be apnea. Then from there, there's going to be either a large amount of fluid that's swallowed, or you're going to get that laryngospasm that keeps that water from coming in, and you get dry drowning or asphyxiation from the laryngospasm, or you get the glottis that opens up and floods the alveoli with all of that fluid. That patient will vomit. They'll retch and they'll vomit and they'll try to eliminate all of that fluid. In that, they'll have a big gasp and then they will aspirate both the vomit and the fluid again. Then they will have seizures. They'll go into a coma and then ultimately succumb to the situation. Things that we look at for patients that are going to do better or more favorable factors, these are things that we want to kind of look for when we have patients that are in these traumatic situations. Ideally, the younger they are, the better outcome they have. The shorter time they have submerged, the better. The colder the water, the better it is. There's fewer contributing injuries, the better, meaning they don't have a head injury or a traumatic brain injury on top of their drowning injuries. The less they struggle, the better. The better the CPR, the better the outcome. And if it's accidental compared to intentional, these patients have better outcomes as well. So if we can get a history, if we can get an understanding of what is taking place, then we can kind of have an idea of what the results are going to be when we have these victims that come in. And it's so important for us to know and understand high quality CPR. When we look at the findings of these patients that are coming in, if they are breathing, they're either going to be apneic and they're not going to be breathing at all, or they're going to be tachypnic. Remember, they just washed out all that pulmonary surfactant. They have all of that interstitial edema and alveolar swelling and this desire of the alveoli to want to collapse on themselves. So of course they're going to be tachypnic. They're probably going to be taking shallow breaths, which leads to needing a faster respiratory rate in order to maintain that minute ventilation. They're going to be tachycardic from the hypoxemia. They're going to be hypertensive from the struggle. Cyanotic, we talked about the frothy secretions, whether they're pink or white. Pallor, this is somebody that is severely pale. So they're going to look very off-colored and very, very, very pale. We're going to have fine crackles. You're going to have decreased volumes and capacities. When we have these patients that are coming in and they are breathing on their own, having spontaneous breathing efforts, their ABG is going to look like acute ventilatory failure with hypoxemia if it is a severe case. Early on, you may have that acute alveolar hyperventilation. At some point, they're going to lose that race, that infinite race of needing to stay tachypnic with taking these teeny tiny lung volumes. It's not going to eliminate enough CO2, which will lead to the acute ventilatory failure. And then when we look at these patients, they're going to look like they have pulmonary edema. When we look at them, you're going to see fluffy infiltrates, just like the bat wing or the butterfly sign. So the difference is when we look at this heart, it does not look cardiomegalous, right? This is not a big heart. We do not have a massive left ventricle, and this patient doesn't have a history of left-sided heart failure. So this would be a non-cardiogenic pulmonary edema that we see here. You get the fluffy infiltrates and you have the air bronchograms that are showing you the differences in atelectatic areas and the areas with pulmonary edema. So chest x-rays, they may not show fluffy infiltrates super early. This typically happens 48 to 72 hours after the initial insult or the initial injury, and it is something that we can definitely we need to be on guard for because it may not happen initially. Things that you need to do if you find a drowned victim. Things that you need to do. You immediately need to remove that person from the water, and you need to call for help and start high quality CPR if necessary. So that is compressions at least 1.5 to 2.5 inches and fast and hard. We do not want it to be faster than 120 beats in a minute, nor do we want it slower than 100 beats in a minute. So you need to have that great range of 100 to 120 beats per minute, and you need to allow for full recoil. That chest needs to fully lift in order for the heart and the ventricles to fill with blood and fluid. Then you compress really hard. Hands-only CPR is going to be very, very good until we can get EMS or first responders there that may have oxygen, and we can provide positive pressure breaths via a resuscitation bag. The ideal situation is the patient needs to be submerged less than 60 minutes and in cold water. The body is a phenomenal tool that will protect itself. It'll go into this state of hibernation, and you'll get vasoconstriction, and you will get a preservation of the brain, heart, and lungs as much as it possibly can. Ideally, you want to remove these patients' clothes as soon as possible because it's going to be a conductor. Wet clothes or water itself is a great conductor for losing body heat, and we do not want these patients to lose body heat and go into a state of hypothermia. It's not necessarily a bad prognosis, but it is something that we definitely need to be on guard for, is those patients going into hypothermia. We want to replace those cold, wet clothes with dry, warm clothing, and especially of areas of high heat loss, like the neck, the head, the armpits, or the axilla, and in the groin or the inguinal areas. Those are all different areas that we want to make sure get covered and protected when we are trying to rewarm these patients. The other thing is, when these patients come out from being submerged, their pupils may be fixed and dilated. Typically, fixed and dilated pupils are a bad or an ominous sign. That is something that we do not want. So when we have these drowned victims, it is not necessarily a bad prognosis. It does not mean that they are going to be vegetables. We do not have that information whether they have expired until we know that they are normothermic. So if somebody is hypothermic and they have blown pupils, we do not know if that patient has truly expired, and CPR needs to continue until that patient is normothermic and we have no other reversible causes that we can treat, and there's nothing else that we can possibly do. So part of the monitoring, in order for us to identify if this patient is normothermic or hypothermic, is they need to have rectal temperature monitoring or internal monitoring. Your rectal temperature is going to be your most accurate. It's your most accurate form of measuring that patient's temperature. So if we can get some rectal temperature monitoring, that's going to give us some insight as to, has this patient truly expired, or do we still have more work to do? The last thing is, when we look at our spontaneous breathing patients, spontaneous breathing patients does not automatically mean that they're not going to end up on mechanical ventilation and life support. Some of these patients that are spontaneously breathing, we want to target a PaO2 of 60 millimeters of mercury with an FiO2 of about 50%. If your patient is apneic or your patient goes into acute ventilatory failure, these patients are going to need mechanical ventilation. When they get intubated and they're on mechanical ventilation, we need to make sure that we are treating the acute ventilatory failure appropriately and the hypoxemia accordingly. So if you have somebody that's in refractory hypoxemia, am I going to use lower PEEP settings? No. What is the compliance of this patient going to look like? Remember, all of that fluid washed out their pulmonary surfactant. They're getting an increase in alveolar consolidation. They're getting alveolar swelling, and now you're getting pulmonary capillaries that are flooding the alveoli with fluid as well. So what do you think the compliance is going to be looking like? What do you think their hysteresis would look like? Am I going to start this patient out on 3 centimeters of water or 5 centimeters of water of PEEP? Or should I go ahead and open up that alveoli a little bit earlier so that we can stent those airways and have more surface area for gas exchange? Absolutely. The other thing is these patients, because their compliance is so poor, is they are going to be at risk of ventilator-induced lung injuries, volume trauma, barrel trauma, atelecta trauma, big time atelecta trauma. And so we need to use what's called gentle ventilation or a strategy that is permissive hypercapnia. I don't like saying strategy because it can be confusing between volume strategy and pressure strategy. But when we look at permissive hypercapnia, this is a vent management technique, and we're talking about allowing that patient to be acidotic, having a pH of 7.2 to 7.25, not necessarily looking for a target pH that's within the normal limits, and allowing that CO2 to be a little bit higher using lower tidal volumes, higher PEEPs, so that we can have more of a gentle ventilation. These patients, they're going to need help with their blood pressure. At some point, they're going to be flooded with all of this extra fluid, and they're going to need diuretics. And diuretics are going to help eliminate. They're going to help eliminate all of that extra fluid, and they're going to need inotropic agents or vasoconstrictors to help with managing all of that fluid. So depending on what we've got going on, we may need some vasoconstriction and we may need some diuretics to help eliminate all of that fluid. Remember, the lymphatic system is going to be working in overdrive. It's going to be working in hyperdrive to try to get rid of and eliminate all of that fluid. So one, we need to make sure that we have a MAP greater than 60 to 65 so that our kidneys are functioning. Because if our kidneys aren't functioning, then we're not going to eliminate all of that extra fluid anyways. So then we're going to have all of these compounding problems that we have to really worry about. The other thing is when we start warming these patients up. When they start warming up, what happens to the vasculature? It starts to vasodilate. So we don't want vasodilation. That's going to lead to hypotension. Poiseuille's law. He's everywhere, you guys. So we definitely need to make sure that we are being aware of our warming techniques and not warming them too much, causing vasodilation, leading to a decrease in that blood pressure, leading to hypotension. So some of the things that we can do to help warm these patients up is we can use heated IV solutions. So these patients can get their normal IV fluids, but instead of it being hung and ran at room ambient temperature, you can have them heated and then delivered. The other thing is we can do a heated lavage to the gastric region. You can do a heated lavage to the intrathoracic region, the pericardial region, peritoneal spaces, bladder, and even the rectum. What we're trying to do is try to warm this patient up. But again, every time that we warm them up, we need to be mindful of the vasodilation that happens secondary to the change in temperature. The other thing is we can use external heating techniques, whether that is blankets, whether that is warm baths. These patients can and have been dipped into warm baths to help warm them up. As respiratory therapists, we can use active humidity. We can use heaters where we set the temperature of the heater a little bit hotter, 39 degrees Celsius, so the patient can get heated internally that way. There's a heated Hubbard tank, which is a dunk tank for these patients to be dropped into, and even ECMO is another source or resource that we can use when we're trying to take care of these drown patients. So that's what we've got when it comes to drown victims. It is a quick, fast, and it's a quick, fast lecture here, but it is definitely something that we need to be on our toes for. You never know when this patient is going to come in, and they're definitely going to need your best. So let's make sure that we're doing everything that we possibly can to take care of them the very best way that we can. And when they end up on mechanical ventilation, again, that saying is, when we commit somebody to mechanical ventilation, what we're saying is we can breathe better than they can on their own. So we dang sure need to make sure that they are breathing appropriately with the mechanical ventilation. So when we get these patients that ultimately end up on mechanical ventilation, we need to make sure that we're doing all the things that we possibly can to be lung protective, using these different mechanical ventilation techniques like gentle ventilation or permissive hypercapnia, allowing the patient to be acidotic so that we can be more strategic and lung protective with our mechanical ventilation strategies. Also, you have to understand the physiology of how the body is going to change, whether it's cold and hypothermic or it's being heated up. What's that going to do to blood pressure? What's that going to do to the function of the kidneys? And all of those other components are very, very important when it comes to taking care of these victims.